In the name of Allah, the most beneficent, the most merciful. Separate diet plans need to be drafted for a cirrhotic patient, for a cirrhotic patient with ascites, and a cirrhotic patient with hepatic encephalopathy. To draft diet plan for a cirrhotic individual, the following points should be kept in mind. Number 1. The cirrhotic patients are usually malnourished with nutrient deficiencies of zinc, magnesium, selenium, and the vitamins A, B1, B2, B9, and vitamin C. Due to zinc and magnesium deficiency, leg cramps can stop cirrhotic patients from sleeping at night. These patients should undergo monitoring of their potassium levels, as low levels can cause leg cramps. Vitamin D is another deficiency in cirrhotics, and so some clinicians think that vitamin D deficiency may be associated with this problem. So, diets containing zinc, magnesium, selenium, and vitamins A, B, C, D, and E may prove beneficial. So, magnesium-rich dietary components are beneficial for cirrhotic patients. Likewise, zinc-rich dietary components may also be beneficial for cirrhotic patients. And selenium-rich food sources should also be given preference. The second point to be kept in mind is that one of the most significant nutritional problems in cirrhotic patients is muscle wasting and sarcopenia. Thus, it is critically important for cirrhotic patients to maintain their muscle mass. Due to depleted glycogen stores, the muscle proteins are broken down during nighttime sleep to maintain the blood glucose levels by gluconeogenesis. One way to avoid this is by having a late night snack, which helps prevent the development of catabolic phase with muscle loss. As late night snacks may help maintain blood glucose levels at night, for most cirrhotic patients, a nighttime snack of approximately 700 calories and approximately 25 grams of protein is recommended for maintenance of muscle mass and prevention of muscle catabolism. Biochemically, BCAA supply muscle tissue with carbon skeletons for replenishment of alpha-ketoglutarate. Alpha-ketoglutarate is depleted during hyperammonaemia through enhanced amination to glutamate, followed by conversion to glutamine through further amination. BCAA and glutamate concentrations in plasma and muscle tissue are reduced in people with cirrhosis and hyperammonaemia. BCAA supplementation increases plasma levels of BCAA and reduces the ratio between the aromatic amino acids and BCAA. BCAA may further enhance detoxification of ammonia. The addition of BCAA reduces cerebral efflux of aromatic amino acids across the blood-brain barrier and also reduces the imbalance of the synthesis of dopamine, noradrenaline, and serotonin. However, the favorable effects of BCAA supplementation might be associated with three adverse effects. Number 1, draining of alpha-ketoglutarate from TCA or cataplerosis because of conversion of alpha-ketoglutarate to glutamate and glutamine by acquisition of amino group released during the catabolism of branched chain amino acids or BCAA. Second, increased glutamine content and altered glutamatergic neurotransmission. And third, activated glutamine catabolism to ammonia in the gut and kidneys. Cirrhotic patients are advised a low sodium diet if they have decompensated disease with ascites. It is important that patients be educated regarding a low sodium diet, especially patients with poorly responsive ascites. Some patients with more advanced liver disease must be on a fluid restricted diet, which is difficult because they often feel thirsty. However, if they drink too much fluid, they will retain it. and develop more ascites or third space shifting. Aldosterone is already active due to third space shifting. Added salt can further potentiate the salt and water retention. If cirrhotic patients are overweight and have non-alcoholic liver steatosis, they should be on a calorie but not protein restriction. They should also avoid fructose and sugared beverages, as such beverages are a frequent cause of weight gain and can be easily removed from their diet. Overnutrition may pose risk of further liver damage because acetyl-CoA is derived from glycolysis of glucose monomers released after ingestion of excess carbohydrates are channelized into the pathway of fatty acid synthesis, which are used to synthesize triacylglycerol or TAG. TAG is exported out of liver in VLDL, packaged with ApoB100. Since diseased liver cannot synthesize ApoB100 for VLDL packaging, the liver parenchyma becomes infiltrated with lipid droplets that cannot be exported out and cause further damage. The cirrhotic patients should avoid saturated fat-enriched diets with excess sugar content. So there is a long list of foods that are considered unhealthy for cirrhotic patients. Some of the nutrients that cirrhotic patients can be deficient in also have potential toxicity. Vitamin A is an example. Many patients with more advanced liver disease, especially those with cholestatic liver disease, can develop vitamin A deficiency. If patients receive too much vitamin A supplementation, they can develop toxicity and liver injury. Certain other nutrients, such as selenium, also have potential toxicity. A patient can be deficient in selenium but can develop toxicity if he or she receives too much supplementation. Importantly, some of these micronutrients, such as vitamin A, have a relatively narrow window between deficiency and toxicity. So instead of supplements, these deficiencies should be catered for by natural food components. Many patients use complementary and alternative medicine, such as herbal supplements. The one that is most widely used is milk thistle. It has beneficial antioxidant properties and is probably safe in liver disease. However, it is unclear whether this supplement actually improves liver function. To devise diet plan for a cirrhotic patient, the focus should be on dietary prevention of nutrient deficiencies, along with protein intake to prevent against catabolism and sarcopenia. First, let's devise a diet plan for a cirrhotic patient. Later, this diet plan can be tailored to meet needs of a cirrhotic patient with ascites or a cirrhotic patient with hepatic encephalopathy. So, whole grains are an important source of micronutrients and fiber. These should be included in the diet of cirrhotic patients. Now, coming to fruits, these fruits may be consumed in recommended amounts. Next are the vegetables. These vegetables may be consumed in recommended amounts. To meet the needs for protein, certain pulses may be consumed as per need. These fats can also be consumed in small amounts. Linolenic acid and omega-3 fatty acid derived from fish and plant oils reduces many disease states including heart diseases. So it should be used as a fat source in diets of cirrhotic patients. Next, alcohol. Alcohol and alcohol metabolism can interact with nutrients such as omega-6 fatty acids or linoleic acid and cause lipid peroxidation with oxidative stress and production of certain highly reactive toxic metabolites. When cirrhotic patients consume alcohol, instead of drinking and or eating food with nutritional value, they can become malnourished and have difficulty moving around and performing their daily routines, which often leads to further deterioration of their health. So that is how the reactive oxygen species damage the cell membranes. So now back to the drafting of the diet. Diet plan can be devised by filling in the portions in my plate. To fill in portions in my plate, three things must be kept in mind. Number 1. Which fruits are suited for cirrhotics due to high potassium, magnesium, zinc and selenium content. Secondly, how much quantity is allowed per day. And thirdly, how this quantity may be divided into 3 to 5 servings per day. The recommended allowance per day may be noted from my plate website. For fruits, 2 to 2.5 cups of fruit are required per day. This may be divided into 5 half cup servings per day or 3 by 4 cup servings in a day. Further, my plate recommendations define 1 cup of fruit may be replaced by half cup of dried fruits. So, cirrhotic patient's diet chart may replace 1 cup of fruit serving with 3 half cup dried fruit servings per day to meet micronutrient requirements. Now coming to the vegetable portion of my plate. For this we list the vegetables which may be consumed by cirrhotic patients with special emphasis on potassium, magnesium, selenium, zinc rich vegetables. Instead of commercial salt dressings, olive oil and vinegar may be used to add flavor and taste. Then the recommended amount is noted from my plate website, which recommends 2 to 3 cups daily, where it defines 1 cup as a cup of raw or cooked vegetables or 2 cups of raw leafy salad. Dividing 3 cups into 3 meals makes 1 cup of raw or cooked vegetables per meal or 2 cups of salad greens per meal. Next, coming to the grains portion, the grains are listed. Recommended portion from my plate is noted, which is 3 to 3.5 ounce equivalents of whole grains. Quantity of 1 ounce equivalent is noted from my plate recommendations. As a rough estimate, it may amount to 1 slice of whole bread per meal. These are very important for cirrhotic patients because of their micronutrient content. Next, protein sources are listed. Ounce equivalent recommendation is noted from my plate, which is 6 to 6.5 ounce equivalents per day. Protein sources rich in branch chain amino acids are preferred. From among these sources, plant sources of branch chain amino acids are given more preference as compared to animal sources of branch chain amino acids. So, a protein serving may constitute approximately 2 ounces of chickpeas or red lentils, which are rich in branch chain amino acids, or occasionally 2 ounces of salmon or tuna fish per meal, as these fish are rich in branch chain amino acids, or 2 ounces of boiled eggs, which are also rich in branch chain amino acids. Alternatively, 2 ounces of peanuts may also be recommended to fulfill the protein portion, and these are also rich in branch chain amino acids. So, likewise, breakfast may be designed by picking up recommended food items with special preference to fruits rich in micronutrients and protein sources rich in branch chain amino acids. Similarly, lunch may be designed from recommended food items, and dinner can also be designed. An additional thing that a cirrhotic patient may need is a late night snack. Combining all portions together may look like this. So, diet for a cirrhotic patient should be good for weight loss and low in sugar and fats. Cirrhotic patients with ascites may follow the same diet plan as cirrhotic patients without ascites, but they should be advised salt and water restriction to avoid aggravation of ascites due to third space shifting of fluid. Clinically, hepatic encephalopathy is a range of neuropsychiatric disturbances among patients with liver disease. It is characterized by personality changes, intellectual impairment, and altered level of consciousness. The manifestations of this syndrome range from mild abnormalities only detectable by psychometric testing to confusion and coma. The development of hepatic encephalopathy is a sign of decompensation and a marker of poor prognosis that may herald the need for transplantation. The American College of gastroenterology practice guidelines on hepatic encephalopathy recommend that for cirrhotic patients with acute encephalopathy, protein intake should be started at zero point 0.5 grams per kg per day, with subsequent progressive increase to 1 to 1.5 gram per kg per day, depending on patient tolerance. Fiber increases the rate of transit of food through the intestines, resulting in increased fecal ammonia excretion, and reduces the pH of the colonic lumen, which may result in a favorable microbiota. Compared with meat-based proteins, vegetable protein is poor in sulfated amino acids methionine and cysteine, which are precursors of mercaptans and indole and other toxic compounds which have been implicated in pathogenesis of hepatic encephalopathy. Vegetable proteins are also high in ornithine and arginine, which facilitate ammonia disposal through the urea cycle. A recent consensus statement from the International Society for Hepatic Encephalopathy and Nitrogen Metabolism recommends that patients with recurrent or persistent hepatic encephalopathy should consume a diet low in animal protein and rich in vegetable protein. Typically, a 30 to 40 gram vegetable protein per day can usually be achieved because higher levels may cause significant diarrhea and abdominal bloating, which may be intolerable for certain patients. However, it is important to recognize that despite use of the vegetable-based protein for patients with treatment-resistant hepatic encephalopathy, a subset of cirrhotics with acute encephalopathy might still benefit from a brief period of protein restriction. Plasma branched-chain amino acids are reduced in cirrhotics, whereas concentrations of aromatic amino acids, for example phenylalanine and tyrosine, are increased. It has been postulated that the aromatic amino acids would flood the central nervous system because aromatic amino acids and branched-chain amino acids compete for the same transporter to cross the blood-brain barrier. To sum up, cirrhotics need whole grains in their diet to fulfill the micronutrient demands. Sodium intake should be reduced. Preferred fruits and vegetables include those with high potassium, zinc, magnesium, and selenium content. Nuts should be included as protein sources because of their micronutrient content. Instead of branched-chain amino acid supplements, natural sources of branched-chain amino acids like salmon fish and tuna fish, eggs, chickpeas, and red lentils should be preferred. Whereas plant sources of branched-chain amino acids may be preferred over the animal sources of the branched-chain amino acids, but it all depends on the patient's condition and the tolerance.